Hello, I'm Dr. Dattoli, and I want to thank you for once again posing some questions to me. I know we did this a little over a year ago, PCIG group from the greater Cincinnati area in northern Kentucky. Last year we had a grouping of questions. This year I have a group of questions, a little more challenging ones, and controversial ones for sure. Many I have a suspicion were actually maybe a request by a physician, since it kind of leaves the general patient bound question, although, hey, you guys may be really bright, and I know last year you had some very challenging questions as well. So let's go on. I have with me paper, 3 pages with 10 questions, and a few of them I may decide not to answer, and let's just see how it goes. So the first question asks about a member was refused at Sand Lake Imaging when he sought Fereheme imaging. And the question is this a death sentence for lymph node imaging? Well, let me tell you what's really going on. The group in Orlando has done so many Fereheme studies that the doctor, especially Dr. Bravo, but also his colleagues, they're brilliant people and probably the sharpest radiologists I know of, and I've worked with radiologists from Harvard and Yale and Sloan Kettering, and this group in Orlando is second to none. I've even worked with the group in the Netherlands, where I used to send patients for Combidex studies, which Fereheme is basically the same molecule, very, very similar. After doing so many Fereheme studies, Dr. Bravo began to identify some morphologic changes within lymph nodes on other MRIs using another contrast medium, and became very excited about this. And while we have accrued enough patients for using ferumoxytol or Fereheme to write a very powerful paper that's already done, we have the RAD path, meaning if it's positive on the Fereheme and if you biopsy it, it's real. We have that data, and the predictive accuracy is so high that there would be no need for a patient who has a abnormal lymph node by Fereheme to have to do a lymph node dissection. Well, what's transpired from having done so many of the Fereheme studies and being brilliant radiologists is they picked up morphologic changes of lymph nodes using a specific agent, another reagent, not Fereheme, which is a contrast agent typically used to better enhance T1 and T2 weighted imagings for diffusion purposes. But they picked up in these morphologic changes, which is an architectural change of a lymph node, and were able to predict which lymph nodes were going to be positive. So now they're, and have been, biopsying lymph nodes without the use of ferumoxytol or Fereheme, and they're coming up with the same results. So they're onto something. By the same token, we were going along the path to get this FDA approved, Fereheme that is. We already have 5 abstracts and presentations, and we have another one coming up in Chicago in November. But during this period of time, Fereheme became black boxed. What does that mean? Well, when the FDA black boxes something, it means that they're just posing a warning, and a fairly strict warning, that this reagent may cause problems. Combidex had the same issue, by the way, and they were black boxed at one time. I think it gave the group in Orlando some leeway to say, you know what, we're not going to use Fereheme because it's been black boxed. And that's probably what they're telling you, when in reality it's just they're very enthusiastic about what they're doing in terms of biopsying lymph nodes in general that they can just pick out of an MR scan. And so it's just basically giving them an excuse to do it. And mind you, it's been black boxed a long time ago. It was March, April, and they were scanning with Fereheme up until almost August, knowing that it was black box. But again, I just think this was fuel for their fire to continue doing something else that they're interested in. Again, having accrued enough patients to satisfy a powerful journal article on Fereheme. So that's already done, and we're marching in that direction. We'll see what happens once Fereheme has its black box removed, which it will. My better judgment is that within a month or two. Will they go back to offering it? I think they're just going to go back to offering it. The good news about their current position is that when they're using this morphologic data with another contrast medium, there's no charge to the patient because it is an FDA-approved agent. Fereheme was also an FDA-approved agent, but it was not labeled for imaging, whereas they're using another reagent which is labeled for imaging. So it does take it does save the patient a lot of money if they're willing to go that direction. On my last discussions with them, what they told me was when Fereheme loses its black box, they'll probably just offer the patient A or B. You can have Fereheme or you could have another reagent, and if you want the Fereheme, it'll cost a little money out of pocket because they have to pay for it, okay, because it's not FDA labeled for imaging. That's the story. That is the story. You may have heard differently, even from the group at Sound Lake Imaging, because, as I said, this was fuel for their fire to go in a different pathway, and we've already satisfied the criteria for the number of patients accrued to make a powerful journal article. What else is Fereheme used for? Well, it's used for patients who are undergoing dialysis, and they develop anemias, and they're infused with it. Interestingly, they only recently got approval for patients who just have chronic renal failure without being on dialysis. So this was huge. That was a huge win for them getting FDA approval for that. But because of this NCI trial, they backtracked and they found that several patients had anaphylactic reactions and several patients died. Well, you're talking about a group of people who are sick. Okay, they have chronic renal failure, many on dialysis. And so you can expect that that grouping of people will have reactions to all kinds of contrast reagents. But they pulled a black box on both FDA label and the non-FDA label. So that's where we are with respect to the black box as has been implemented by the FDA. So therein lies the reason why the FDA put this black box in place. Meanwhile, using the lower dose levels in Orlando, we've had 0 toxicity. So no patient has had an anaphylactic reaction. There's been no deaths. Okay, so it's all about the dose. I recently spoke to the powers that be at AMEG Pharmaceutical, and they were unaware of our data, which was really interesting since we've been out there talking about it, different cities at different venues since 2011, 2012, and but they were very interested to find that we had no toxicities using it. So that's kind of the story behind black box in question number 1. We'll now move on to question number 2. And I really have to tell you that a lot of this should be answered by Dr. Bravo. But I'll just go on to say you've made some categorical statements right from the beginning, and in A and B, you're correct with respect to the mechanism by which Fereheme works. Under 2B, the last paragraph says, if this is the mechanism by which it works, is it correct to assume that Fereheme really only applies to lymph node scans? How then do you look for cancer sites in other tissues? Well, because of the fact that when using Fereheme, you're basically doing a whole body scan. You're also doing a whole body MRI. You're also doing a whole body CT scan. you're also most probably having a sodium fluoride F18 PET bone scan, CT bone scan. So in reality, you're getting a lot of testing done. So you're not, so while you're perfectly correct, it's a lymph node attracting reagent, and it will detail exactly which lymph nodes are involved, which is great for me. And we fuse our technologies with Orlando, so it's very nice for the radiation oncologist. It's very nice for me to have their images fused with my images with our scanners. This is a lymph node reagent, but it's an all-encompassing body scan. So the MR, the CTs, the PET scans are going to tell us everything about a patient. So when I send a patient to Orlando, I'm getting a complete restaging or initial staging on the patient, really from head to toe, or at least from the neck down to the groin. Okay, so let's move on to question number 3. So I just had a repeat Cincinnati multi-parametric MRI. The first was December 2014 and showed only 2 smallest lesions in the left peripheral zone. The new scan showed these 2 have grown, 2 new ones, and probably seminal vesicle invasion. Little evidence of other spread. Biopsy in March 2015 came back showing Gleason 3 + 4 = 7 in less than 20% of the total cores. What do you recommend for this healthy 67-year-old? Well, I just have to say that there's another question that comes up, and it's asking specifically about, I believe it's 7A, a patient who should decide regarding surgery and radiation, and states that the data supports the patient living longer with surgery. I really want to see the data that you're looking at, because I've spent my career being a data hawk on surgery, and at this point in time I'm aware of one study, a large Swedish study, which is a retrospective study, and there's some flaws within the study which compared radiation with hormones to surgery with hormones for high-risk disease, and they came up with a marginal advantage with surgery. Again, this was a retrospective study, and what it doesn't tell you is when the hormones were started. It doesn't tell you if the patients who failed the surgery got radiation, and that's a historic flaw in the surgical literature, because many patients who are listed as these guys had surgery, these guys started with radiation. What they don't tell you is these guys had surgery plus radiation plus hormones, and and they're living longer. There really is no good data. Interestingly, I'm aware of all the data, be it surgery or radiation for high-risk disease. I live and breathe high-risk prostate cancer, and so I've been involved for over 20 years with high-risk disease. And I'm also aware of some articles which would refute the fact that a patient is living longer having surgery for high-risk disease. This is a journal article from Oncology, volume 22, number 9, in 2008, and how to avoid recurrence. And what you'll see is at the very top, these are all radiation series from, actually, I'm on the top, I think it says Dattoli, and then there's the Schiffer Cancer Center, there's Mount Sinai Hospital in New York, and Seattle and Atlanta. Meanwhile, you have the lower curves going down, down, down. Those are all top surgical institutions, and that includes the Mayo Clinic, Northwestern, where Dr. Catalona is an expert at surgery, and I respect him greatly. And finally, Johns Hopkins, and who can fault Johns Hopkins for surgery? I mean, they're considered to be the #1 surgical center for prostate at this point in time. This was actually for patients having Gleason 8 to 10, so that's high-risk disease. Again, we could look at patients with PSAs over 20. And once again, you'll see those straight lines going across, and it's my data, it's a Schiffer Cancer Center data, it's the Atlanta data, it's the Seattle data, and then you'll see the other meandering curves going downwards. It's the surgical data. So I can make a pretty strong argument that patients having high-risk disease, which if your seminal vesicle is involved, and if a multi-parametric MRI showed seminal vesicle involvement, it's typically true. You got seminal vesicle involvement. I will give credit to multi-parametric MRIs. They can show seminal vesicle involvement, and you have a Gleason 7 tumor. So having said that, I would veer in the direction of radiation. You're a healthy 67-year-old patient, you want the best outcome, you go to radiation. Interestingly, there is a study, it's a randomized study called ASCEND RT, -RT. It's ASCENDE RT. And what it looks at is radiation, IMRT versus IMRT and seeding. There are two other studies which looked at radiation alone versus radiation and seeding from the standpoint of cure and the standpoint of side effects. Both of those studies did come out in favor of the combined group, okay, namely radiation and seeding was better than radiation alone. Makes perfect sense to me. And now the ASCEND trial, the ASCEND-RT trial, again, randomized, a prospective trial, is showing the same. It has not matured to the level of an overall survival benefit, but it will, because there's already enough statistical power and variance between the curves that it's going to go in that direction. And again, in the other two studies, they showed that, interestingly, that the combined regimen was not only superior from the standpoint of survivability, but also less toxicity, which is interesting because many people think that seeding alone has less toxicity, and I've done probably more seeding alones than a person in the world, and I can speak to that effect because when giving a little of each rather than a lot of both, after all, when you do seeding alone, you're carpet bombing the prostate. But it brings up another point, which I think it may be brought up in one of these questions, or it may be brought up by a particular physician, I don't know, and that is that when you get radiation, it's, how it's said, it was a gift that never stops giving, that your side effects continue to go on. And there's been recent information that, the side effects go on to about 5 years. I don't dispute that. A patient having radiation full course will typically have side effects occur down the line, and it usually hits its peak between the 2nd and 5th year and doesn't go any farther beyond that. But the fact remains that that's a truth. But what I've also found is that when you combine radiation and seeding, you're switching horses, you're not giving the full course of radiation, and actually that group of patients is completely different and should not be pooled into the group of patients having radiation. So when you're thinking about having radiation and making a choice between radiation and surgery, and you've heard this nasty wording about radiation causes downsides in the future, well, think about combining radiation and seeding because it's completely opposite. What I see in my practice, and we follow every patient closely, is that they may have their acute side effects, maybe even a little proctitis and irritated bladder symptoms, but they go away quickly, and going into the 2nd to the 5th year, they improve from the standpoint of late effects, which means their urinary symptoms, their any rectal symptoms, their erections improve. Things improve, they don't get worse. So they actually go back to baseline. It's for that reason that we do a lot of baseline studies here to get you back to baseline, because we want to know exactly where you started from. And so before you're ever treated, we have ways of getting baseline studies because that's part of your record, and when all is said and done, I want to get you back to where you started. And we've seen that, and there's a great disparity between radiation alone and radiation combined with seeding. Now, some patients need radiation alone, but those are typically patients who've already had surgery or have relapse disease in lymph nodes, something I'm going to be talking about. But it's different because it's typically in a different area, and we have to talk about other sites of the body. If it's truly a prostate recurrence or prostate bed recurrence after surgery, yes, that patient will have to have full course radiation. But you know what? It's so uncommon to see a patient having surgery who doesn't have erectile dysfunction anyway. It's just so common that I don't think that it really should be part of the decision making. And you need it anyway. You already had surgery and you failed. So, you know, what do you have to lose? I mean, you're already having sexual dysfunction. I know that. And we see this on our monitors when we do vascular measurements in patients who've had surgery, even nerve-sparing surgery. And so there's really nothing to lose. There's only to gain from the post-operative radiation. But I'll be talking about that in, I think, another question that comes up. Just one other note on question number 3. Person having Gleason 7, seminal vesicles involved, which basically is the same answer for a patient, I believe it was 7A. I was talking about high-risk patients. There's also a meta-analysis which was done, and that was in the British Journal of Urology. You can look it up. It was the primary author was Grimm, Grimm, and it was a meta-analysis of over 15,000 patients. Again, looking at every type of modality: seeding alone, combined radiation and seeding, radiation alone, surgery, and it basically shows that for high-risk patients, combined treatment, radiation and seeding wins out. Okay, and I was cited in that paper as actually having the highest cure rate with combined radiation and seeding, which doesn't surprise me, just because I've been doing it for a long time, and I think I've been at war with high-risk disease for a long time. In that study, by the way, even the intermediate group fared better with the combined treatment. Okay, so let's move on to question number 4. I have a pacemaker, so I cannot have an MRI. Is there any effort being made to enable someone like me to have an MRI? Yes, there is. There are recent pacemakers. One I know of, it's called the Revo MRI SureScan pacemaker. And this is compatible with an MRI, and if you're about to get a pacemaker, or, you know, anyone about to get a pacemaker should probably be asking the question, you know, because at some point in time, you know, from golfing or doing whatever you do, you may injure a shoulder, or you may injure a knee or a hip, or, you know, just exercising, you may need an MRI. So clearly they're making inroads with respect to pacemakers. But from the standpoint of where we're at right now, if you don't have that kind of pacemaker, well, you could undergo some other studies. There is the carbon acetate C11 choline study, which is done in Phoenix. There is the C11 choline study, which is done at the Mayo Clinic. And those studies can be done with a pacemaker because they don't use MRs. I do believe that the nanoparticle studies are better. Okay, my experience has been that there's a larger false positivity and a larger false negativity associated with those studies. So in other words, we've taken patients who've had positive biopsies, with those C11 choline studies, we've taken patients with positive lymph nodes, biopsy them, and they come back negative. Then we've taken patients who have large lymph nodes that didn't light up, biopsy them, they came back positive. But having said that, there's still good studies, and I don't mean to berate anyone. I think they're doing a very good job in Phoenix and at the Mayo Clinic. But let me say I'm biased. I've been working with nanoparticles since 1990, and there's nothing like it. And I think most radiation oncologists, once they get used to nanoparticle technology, they're going to love it. And for that reason, I really want to go forward with Fereheme and move on with Fereheme. Number 5, this is kind of an ugly question, and you know, ugly question gets an ugly answer, and it's basically Colorflow Doppler. You know, we've had some real pushback from the local Cincinnati docs who basically call the Colorflow Doppler quack science. Discuss the differences of the MRI-guided biopsies which are being done at the University of Cincinnati, and which is so heavily marketed, advantages that you believe the Colorflow Doppler offers. First of all, let me just say, it's unfortunate that any group of doctors has to call it something like this quack science. What they basically should tell is the truth, and that is say, you know, this Colorflow Doppler ultrasound that you keep talking about is 10 to 20 times the price of the ultrasound that I'm using. The reimbursement is exactly the same. It doesn't make fiscal sense for me to do it. Here, all we do is treat prostate. So it does make fiscal sense. I do thousands of 3D Colorflow Doppler ultrasounds. We can have the best Colorflow Doppler ultrasounds in the world, and we do. So, Colorflow Doppler, quote-unquote, quack science, I don't think so. Okay, I've been living and breathing Colorflow Doppler ultrasound for over 25 years, and I'm aware of other physicians, not many, we all know who we are, who use the same science and are finding the same results, and that is, if you have cancer, we're going to find it. I recently actually gave a talk and a publication at the largest, it's actually the largest international GU symposium held every year. It's the ASCO GU, and I demonstrated that with certain patterns that only someone who reads Colorflow Doppler ultrasounds could identify. With certain patterns, there's a 97% predictive accuracy of finding cancer, and those cancers are typically of the higher grade. And we also identified other features which may demonstrate lower grade tumors. So Colorflow Doppler really is something. And when you start comparing it to MRIs, I previously said I really like multi-parametric MRIs, but by the same token, think about it. It's a static test. So you go through the scanner and you get frame by frame, so you get a picture, okay? But what about if you want to take that picture and go in and out with it? You can't do that, okay? Colorflow Doppler ultrasound, I could look at that tumor, potential tumor, in every which way, and I will. And I'll look at it from right to left, I'll look at it upside down, I'll be able to put it in 3 dimensions and look at it in its entirety to see the vascular pattern associated with it, and I can make a lot of sense out of that, and I can tell exactly where there's a cancer and where there's not. And these are the shortcomings. With respect to biopsies, I like the multiparametric MRI fused with the ultrasound, which is the direction that many are going. However, once again, you're basing everything on a frozen frame. So in other words, you're getting information from fused technologies, and it's saying this is where these studies show the lesion, but it's not saying this is where the lesion is, and I can find it, and I can go north of it and south of it and right of it and left of it, and I can go right in the middle of it and biopsy it. It's just telling me it's a grid. The multiparametric MRI is fused with ultrasound, again, which I endorse, but because everyone can't have a 3D Colorflow Doppler ultrasound for reasons that I brought up with respect to the fiscal expense. At the same token, multiparametric MRIs coupled with ultrasound fusion are very good, but they're fixed frame, and you cannot look at the cancer from inside out in every which way, or around about it. And you need to be able to do that to get to this predictive accuracy, as I mentioned, 97%, which really stands alone. I don't know of any other science or methodology that has a higher predictive accuracy for picking up cancer. So that's my response to Colorflow Doppler ultrasound. It's not a quack science, and I really wish that doctors would just state the truth, and that is, hey, we can't afford it. We don't have the resources for this. We don't do enough of these, and the reimbursement is no greater than my cheaper ultrasound, and I'm going to now fuse it with the MRI. Good idea. It's giving you more information than with the cheap ultrasound. So that's why I'm all for it, because the multiparametric MRI brings in additional information, and so I endorse that. Okay, the local urology group is touting Cyberknife. What is known about this treatment? What is the long-term data? Is there meaningful data? What is your opinion of the claims that Cyberknife is a superior treatment alternative to your DART treatment? First of all, my first question has to be, unless this is a mistaken note here, the local urology group is touting Cyberknife, not the radiation oncology group? Why is that? What is, and again, this is an ugly question, but it deserves an ugly answer. Why are the urologists pushing a radiation modality? What do they know about radiation? Nothing. And so, from my perspective, Cyberknife has been around for a while in other forms. The Lexel Gamma Knife, which I used actually in New York, something called SBRT, stereotactic body radiation therapy. And I always put it in the bin of patients being treated palliatively. They weren't treating curative in a curative fashion. And they were not going to live long enough to experience the side effects that they were going to get from this enormous dose of radiation. So, first of all, I'm going to question the urology group, because maybe that's just a typo, I'm not sure. But if it isn't, I really would encourage you to get online and Google America, Beware the UroRad. It's something that I wrote up several years ago to PACT, and it's been a passion of mine to get rid of this concept of urologists owning radiation centers and driving patients to them. It's ugly, and right now before Congress, and because of me, there's a bill which just needs to be signed off on. Actually, it passed the House. It's before the Senate, to get rid of this idea where urologists can send a patient to a radiation center and get a kickback. That's absolutely wrong. It's in defiance of the Stark laws. But they've been doing it, and their pockets are deep, and they got lobbyists behind it. And so, again, an ugly question deserves an ugly answer, and that's the answer. But it goes beyond that, and I'd have to really describe that to you, and it gets kind of difficult. It all has to do with something called the linear quadratic equation, and radiation oncologists would know about this. And I'm going to try to simplify it by saying, what is the linear quadratic equation? Well, it defines a ratio which we call alpha beta. And there's an alpha beta ratio for acute reacting tissues. What are acute reacting tissues? Well, think of things that turn over quickly. Okay, if you were to burn yourself on your hand or cut yourself on your hand, it heals quickly. Okay, so it regenerates quickly. The epithelial skin heals quickly. That's an acute responding tissue. And there are other examples, the mucosa inside your mouth and your upper GI, your gut is an acute responding tissue. But what's really acute responding tissue is something that's growing really fast, a tumor, a cancer, a malignancy. Okay, so the alpha beta ratio for malignancies is very high. Meanwhile, the linear quadratic equation details that the alpha beta ratio for late responding tissues is very low. What are late responding tissues? Well, bone is late responding, not the bone marrow. The bone marrow is actually acute responding, but the bone cortex, what we think of as bone, your skeleton, is a late responding tissue. The rectum is a late responding tissue. The bladder is a late responding tissue. These are issues because the fact is, when you put it all together, what you really want to do is look at these alpha beta ratios for acute responding tissues, alpha beta ratios for late responding tissues, and you really want to have a high number on top and a low number on the bottom, because on top you have the cancers. So you want to kill the cancers and you want to leave the normal cells like your bladder and your rectum alone. That's something that we could accomplish with radiation. Now let me tell you something that's going on today and has been going on for a very long time, and we often talk about, and that is Europe, socialized medicine. We often talked about the fact that in Europe, if you're treated with radiation, you're only going to get 4 weeks of radiation. You're not going to get 8 or 9 weeks as you do here in the US. And the reality of it is that's because they just lack the resources, and you're going to go in there and be treated for 4 weeks. It's the only your only choice of getting rid of your cancer. Okay, so patients in the UK and elsewhere, they not only accept it. They expect to have damage to the rectums or bladders. And we often talk about this and say, you know, it's unfortunate for those patients because if they had lengthened their course of treatment to 8 or 9 weeks, they wouldn't get into the problems of these late effects of damage to the rectum and damage to the bladder, which don't happen immediately. It takes years and years and years. And I already talked about, you know, patient having full course radiation and how, you know, things do get a little worse for the first, you know, beyond 2 to 5 years, or between 2 to 5 years. Well, when you're talking about late effects with real high dose radiation, like Cyberknife, where you're getting like 5 sessions, yeah, it's convenient, sounds good. Urologists, as you post here, unless again it's the radiation oncology group, are pushing it, but the radiobiology stinks. Okay, it doesn't stand up. You're basically taking that therapeutic ratio and just throw out numbers of 4 to 1, which we like, 8 to 1 we like, because you're killing the cancer cells, you're leaving the normal cells alone. But when you start using these high doses, these hypofractionated big time doses, now we're back to Europe plus. Europe is giving 4 weeks. Now what we're doing is we're reversing the therapeutic ratio to 1 to 4, 1 to 8. So now you're once again getting into the issue of late effects, which we don't like in radiation. And so, you know, buyer beware, because that convenience factor may not be so convenient in 5 to 10 years from now. So, and the data, there is no data, long-term data for Cyberknife, and there is no long-term data to suggest that it's superior to DART. There's no data supporting that it's better than 3D conformal radiation or IMRT. Okay, it just doesn't exist. Go to the therapeutic ratio. Go to the linear quadratic equation. It's all spelled out in radiobiology, which is very deep, and I can go really deep with you, but don't have time. But I hope I have explained it for a layperson. And if you just think about what I've just said, and that also applies to SBRT, which all too often is also being used to treat prostate cancer, and also with Cyberknife, if you think about it, they have to be very precise, and they claim that they are by putting gold marker seeds into the prostate, something I did over 20 years ago just to document the prostate was moving. But they have this robotic arm that goes around, and it supposedly doesn't, just treats the prostate. But you know, if I have my hand open, my palm is the prostate. Okay, these little fingers, those are microscopic elements looming outside the prostate. Well, if Cyberknife is just treating the prostate, it's just treating my palm. Okay, it's missing these guys. So what are you going to do about those guys? What are you going to do about the fact that so many patients who go to surgery and just have this removed, their fingers are left behind, and their PSAs begin to rise because there was extracapsular extension, there were positive margins. It's the same thing with Cyberknife. So now you're actually trying to treat something too precisely, maybe. Not really the case. The reality of it is, it's not that precise, and you do overlap some rectum, and you do overlap some bladder. And for that reason, for example, there's a study out right now by Dr. Yu, and that's from Yale. Yeah, it's in March 14 Urology, and that was a study comparing Cyberknife to other modalities and identified increased toxicity with respect to the genitourinary tract, meaning your bladder and urethra, and also the GI tract, where you're getting more fistulas and fissures with Cyberknife. So, by the way, colleagues of mine, including Anthony D'Amico, who's at the Brigham at Harvard, and Anthony Zeitman, who's at the Mass General Hospital of Harvard, they have both considered Cyberknife to be experimental and maybe investigational at this point in time. A maybe, okay? So these were former presidents of Astro, and Astro has not been too kind to Cyberknife either, and in recent newsletters have denounced it. So again, I don't know if it's a typo, radiation oncologist pushing it, or it's urology pushing it, but if it's the urologist pushing it, then please go to America Beware the UroRad. Just Google it and put Dattoli after it. It'll come right up, and read it. and you'll see what I'm talking about when I say it's ugly. I am aware of 2 recent studies promoting Cyberknife and stating that the alpha-beta ratio does work for prostate. They say this because of the precision and specifically the conformity of the Cyberknife. Mind you, when you're treating with high-dose hypofractionation, you're needing to stay away from surrounding tissues. And so that's the logic, okay? But I think the logic's a bit flawed because you're using gold fiducial markers only to track the prostate. I don't think that you could be that precise. And if you go out 1 millimeter, 2 millimeters, 3 millimeters, 4 millimeters, you're already into rectum, bladder, neurovascular bundles, urogenital diaphragm. These are normal structures now receiving this scathing high dose. And those organs will be damaged with hypofractionated radiation. In contrast, I'd like to say with DART, we can be that precise because we use multiple 4-dimensional technologies to target, and we could be that precise. However, we're also cognizant of the fact that there's also disease which typically leaves the prostate and exits in an extracapsular way, so that we have to vary our precision across the spectrum, be it neurovascular bundles, be it the sidewall, be it the rectum or the bladder. We don't want to treat the rectum or bladder, but we can split hairs there. But the fact of the matter is, with Cyberknife, you have to limit the dose to the prostate only. Otherwise, you're going to damage surrounding tissues. Okay, moving on. Number 7. For Gleason 6's, describe tests which support active surveillance. Okay, this is maybe the most controversial area. Well, this is another controversial question, and so let me first just define what most institutions would determine to be a patient who's eligible for active surveillance. And this would be primarily low-risk patients, and barring a few institutions, low risk would be a patient who has had biopsies and during a biopsy procedure was identified to have only Gleason 6 or less malignancy, nothing from 7 to 10. It would be a patient having a PSA less than 10. It would be a patient who has no more than 3 biopsies within that one biopsy session, okay? And some institutions have it only at 2, and they also, that's the only variance, 2 versus 3, and would not allow a patient to follow active surveillance if within those 2 or 3 biopsies from that biopsy session, if one core has 50% or more cancer within it, patient again is not considered eligible for active surveillance. So interestingly, again, I recently attended the International GU Symposium by ASCO, which is the largest of its kind, and there's more data on prostate cancer than any other, any other conference in the world. And I had every expectation that, since active surveillance has kind of caught on like wildfire, and by the way, another paper which you should probably look up, and it's called Active Surveillance, and then a dark side ? And again, I think if you pull that up, you may find it on my website, you just may find it by Googling it, and it's an article that I wrote because it's troubling what's going on with active surveillance. Some of the troubles have to do with the fact that it's almost become an industry in and of itself. And again, I talk about it in my paper at great length, where the urologists do the biopsies, and they now can tell you, well, we could just do active surveillance, and you're wondering, why isn't he telling me that he's putting me on the surgical table next week? And the reason being is he has nothing. He just gained you for life, okay? Because he's going to see you probably every 3 months and get a PSA, and you're going to live from PSA to PSA. Can you do that? Are you going to be really nervous about that? Most patients get pretty nervous. they're going to do biopsies, and I see this all the time. Okay, I see this in patients who come who have now high risk, if not elsewhere considered incurable disease, having been followed with active surveillance, and the patients are just being bounced around and getting their biopsies twice a year. They're getting multi-parametric MRIs twice a year, and guess what? If the doctor or the urologist sends the patient for a multi-parametric MRI, if he says or tells in his report or tells the patient or tells the urologist that's sending him that the cancer is no longer contained, well, that's the last time that urologist will ever be sending that patient to that radiologist again. So they basically have to say it abuts the edge of the prostate. It's close to the edge of the prostate. But they know that if they bring it outside, which is in contrast to one of your patients we just talked about, who talked about left central vesicle involvement, but that's usually not the case. But the urologist really has nothing to lose, because he can do surgery on you at a time when he deems it necessary, after having you maybe doing active surveillance for years, a couple years or 3 years, whatever, however long it takes. And if you don't want surgery, you'll get radiation, and he owns that too. So this is what's going on, and I see it all the time. So I hate to be just lambasting the urologist, but it is going on. And again, you may want to go to the writings that I put forth called Active Surveillance: A Dark Side, and I'm sure that either Meg Brockett or Virginia Carnahan in my department can send that to you, either both of them to you, including America Beware the UroRad, the other one I told you to read. I think you find it to be factual, and I think you find it to be correct as what's going on today. But what I did do is I did take make a list of some studies which were brought up at this international symposium, where I thought they're just going to be taking it to another level. They're going to be probably talking about doing active surveillance on Gleason 8 to 10s. But to my surprise, it was quite the contrary. And for example, University of California, San Francisco, led by Pete Carroll, urologist, very prominent one, they demonstrated that when they took 312 low-risk men and followed them between 1993 and 2013, okay, that 63% of the patients were upgraded on surveillance biopsies during that period of time. In other words, a 6 became a 7 through 10. Okay, so now would be subject to treatment during that period of time. So they didn't talk about upstaging, meaning going from a T1 to a T2 to a T3, but I'm sure that was happening as well. Meanwhile, when speaking about biopsies, another study, which was out, a combined study from the Mayo Clinic in Rochester, Minnesota, and Duke University, they showed that if a biopsy contained perineural invasion, that was important, and that at a median of 37 months, 76% of the patients, 76% had pathologic progression, and 24% had therapeutic progression. So what basically it said was that a full 76% of the patients in 37 months went from a Gleason 6 to a 7 to 10, and another 24% had therapeutic progression, and in that study showed that most of those 24% had incurable disease. Meanwhile, Harvard, they chimed in, and all the Harvard group, including Dana-Farber, Mass General Hospital, the Brigham of Harvard, and they looked specifically at low-risk patients who went to radical prostatectomy. And these were patients who were considered candidates for active surveillance. And if their PSAs were between 2.6 and 5.0, 33% were upgraded or upstaged at surgery. And that's with having less than 12.5% core biopsy specimen involvement. Think about that. So it's a real low-risk disease. Patient has PSA less than 5, and less than 12.5% core involvement. If you go to the upper end of the spectrum of active surveillance, where the PSAs were between 7.6 and 9.9, and 25% of the cores were involved by cancer or with cancer, 59.8% were upgraded or upstaged. So these are patients who were considered active surveillance patients. So they could have said, you can enter our active surveillance protocol, or you can enter a radical prostatectomy protocol. The patients who underwent the radical prostatectomy, that's what they got. That number, 60%, keeps coming up. And, and I have a few other studies here. By the way, Harvard is currently working on a 30-gene expression genetic signature to try to find out which patients may or may not be eligible for active surveillance. Although I have to tell you, there's a test called Polaris, and we've used it. I've used it extensively, and to me, it's just not predictive. And we're as of a week or two ago, we decided we're just not going to use it anymore. And again, I also see so many patients coming in, who have this Polaris test and it's predicting that they have a low risk of progression, and they've already progressed to having disease to the seminal vesicles and lymph nodes in our bone. So I think we're just not there yet, but I know there's strides being made, or there's efforts being made to get there. Just moving on, just very quickly, again, San Francisco concluded that patients who went immediate RP, who were very low risk, that 20% were upgraded, and if they delayed it for 20 months, 50 to 60% were upgraded. They didn't talk about upstaging, but again, it gets that 60% number. And they said that patients who had active surveillance and who delayed treatment, by the time they delayed and were treated, they really had intermediate to high-risk disease. And so you got to give that some thought, because why are you doing the active surveillance? Well, you're doing it because you want to delay the side effects of surgery. You want to delay the side effects of radiation. But now you're getting into a region where you have maybe incurable disease. So that's you got to really think about that risk-benefit ratio there. And again, I myself do follow active surveillance patients, but very closely, and there's another reason why three-dimensional Colorflow Doppler ultrasound comes into handy, because I can find those lesions and I can define those lesions and when they're progressing. And I use the same criteria that I mentioned earlier, and which is actually Johns Hopkins criteria, or Jonathan Epstein or Valentin Carter's criteria, and that is, again, PSA less than 10, Gleason score less than or equal to 6, and no more than 3 biopsies. And I say on one side, and that's what Johns Hopkins says as well. So we don't like bilobar disease, and no core should have 50% involvement. But I watch those patients carefully, and I come to find patients are scared to death every time they come. And these are patients I could put the fire out right away and do it in a kinder, gentler way than when they end up having disease spread. And then I send them for have to send them for advanced imaging in Orlando or somewhere else, and treat them much more aggressively. And then they get into big time complications. So again, I do use active surveillance, but I use it very cautiously. And speaking of cautiously, Columbia University actually had a publication which started with proceed with caution with active surveillance, because they identified that with active surveillance, low risk disease, 32% of the patients were deemed incurable between 2004 and between 2004 and 2010. 32% of those patients became incurable, and they defined incurable as disease involving bone or lymph nodes or what have you. Sloan Kettering, again, they took active surveillance patients and they said, okay guys, you're going to immediate prostatectomy, are you willing to do that? Yes, they were. 61% of the patients were upgraded or upstaged. Again, that 60% number keeps coming up. Okay. Finally, there was a multi-institutional Canadian study. It was called the Sunnybrook study, and they actually got into overall survival and showed that patients who were selecting to have active surveillance at 15 years had a 68% survival rate. That's not really that good. If you look at some of the studies, my studies with treatment of high-risk disease, I'll get you into a better percentile than that. Okay, and so will others that I mentioned earlier when we talked about the patient who had a sentinel vesicle involvement and Gleason 7 tumor. So I think that kind of sums it up for active surveillance, and I think it's interesting and intriguing. But surely at the GU symposium, I was quite interested to find that many weren't touting it as much as I thought they would be. Let's see now. Well, we already answered 7A, and we'll move on to question number 8. Okay. All right, well, let's move on, and I'm just going to move right to from A to 8A. And it basically said that doctors have issued warnings about using radiation therapy for recurrent lymph node disease, stating there's no evidence that radiation to lymph nodes has any long-term survival benefit. Also warns radiation may lead to a much greater risk of bladder and colon cancer. What is your response to this? Okay. I am aware of the fact that there are doctors who are making these statements, and they're 100% wrong. Let me tell you why. First of all, these doctors are not radiation oncologists, because if they were, they would know that patients who undergo radiation do have or do get a lymphocytopenia. And I know that doctors are checking CD3, CD4 lymphocytes and saying they're declining to the point of patients having AIDS. And I actually found patients who were literally locked in their apartments, or learned that they were locked in their apartments. I actually had a patient on treatment. It was because of his CD3, CD4 count, was locking himself in his condominium while being treated. He would only come here for treatment, then would have food arrive delivered to his place because they didn't want to go outside and catch AIDS. Absolutely absurd. Okay, I have a new associate, and it's really interesting because he's actually written on this topic, and when I brought it to his attention, he was like shocked that that any doctor would not have the knowledge that this does not occur with radiation. The reality of it is we all know in radiation that CD3, CD4 counts decline. But what about other cells? What about things like natural T cell or natural killer T cells? These are far more powerful in terms of scouting around and taking care of your immune system. We all know there's a decline in immune function with patients having radiation, but it's counterbalanced by these memory T cells. So there's actually a memory T cell which goes around and takes care of the immune system. So profound that there's something called an abscopal effect. What is an abscopal effect? Well, that means that when you treat one area, it actually sends out a cascade of events which not only kills that area, but it goes to other sites of your body where cancer may have found sanctuary and eradicates it. And you didn't even treat it with radiation. So again, as a discipline, we know that patients do have lymphocytopenias, and if you check their CD3, CD4 counts constantly, they're going to be low for a while, but they recover. But all you're doing is wasting money, and you're basically scaring patients. You don't want to scare a patient. You want a patient to be positive about their disease. You don't want to be telling them you're going to get AIDS because you had radiation, and lymph node radiation is a horrible thing. Well, let's talk about it. lymph node radiation has been done for a long time, and it's all about lymphocytes. We talked about the CD3, CD4. These are T cell lymphocytes, and other diseases such as Hodgkin's lymphoma. Up until 2000, you would treat every single lymph node from here down to the groin. Okay, and these patients have been tracked and followed so closely and meticulously with studies from Stanford and Memorial Sloan Kettering Cancer Center, and they did not develop opportunistic infections like AIDS. They did not develop secondary malignancies. And if they did, there are actually studies which documented that these patients had some genetic predisposition to developing other cancers by virtue of getting their Hodgkin's lymphoma. Patients having seminoma are commonly treated to their pelvis and retroperitoneal lymph nodes at a very young age. There's no data demonstrating that these patients get opportunistic infections such as AIDS. There's no data that these patients are getting secondary malignancies. All sites of the body. Just think about it. Head and neck, we treat down all the lymph nodes down to beneath the clavicle. Women should know that if they have breast cancer, you treat all their lymph nodes under the arm, up into the supraclavicular region, and often into the neck, down into we call the IMNs, the internal inferior mammary lymph nodes. Did they get AIDS? No. Is there anyone concerned about them getting AIDS? No. Don't you think that a discipline that's been around for 70 years, if patients were getting opportunistic infections, which would be things like cryptococcal meningitis, okay, it would be things like toxoplasmosis of the brain, whereby they would lapse into comas. It would be things like capsicsarcomas, which would be developing these grotesque sarcomas on their bodies. It's a host of things, CMV, retinitis. Don't you think that if radiation was responsible for these kinds of malignancies, if radiation was responsible for these opportunistic infections, don't you think that radiation would have been shut down as a discipline 70 years ago? I mean, general practitioners would be noticing that their patients are getting these weird diseases. Why? And they would look into their history and say, well, at some point someone would say, hey, they all have a common denominator in radiation. Never done. Never happened. They don't get opportunistic infections. They don't get them. So that is a myth. It's an untruth, and it's sad that doctors are out perpetuating that and putting patients through that at a time of stress already. Okay? They should be putting positive feedback into them, not negative. But again, these doctors are citing data, and I did some research myself to find out about the survival factor, because the doctor saying that there's no survival benefit. Well, that's again wrong, and it's based on evidence-based data, which is clinical trials, which it's a shame these doctors don't know about them. But there was an RTOG study, it's called 7506, whereby they irradiated both the retroperitoneal and the pelvic lymph nodes, and they found that they had a astounding 10-year survival. These are patients who would otherwise considered dead. And this is an older study, older trial, and doctors just say, gee, you got lymph node disease, go home, get your affairs in order. But sizable number of those patients were alive at 10 and 15 years. At Sloan Kettering, Dr. Lee did a study and found that at 15 years, there was still, it was between 34 to 37% survivors, overall survival, survivors of the cancer. That may sound like a low number, but again, these are patients who were deemed incurable from the beginning. We're going to be told, hey, all you really have is hormones until you become resistant, and then maybe enter on a clinical trial. Or even back then, they wouldn't even have anything like a clinical trial, and they would just say, get your affairs in order. There's other interesting studies. There's the ARO, A-R-O, if you want to look it up, 9602, which again is very statistically powerful from the standpoint of progression-free survival, meaning the cancers are not progressing with treatment of lymph node disease. And it's so powerful that it's going to translate into an overall survival, unlike what those doctors had said. There's something called the Milan matched analysis trial, and again, this was a post-operative trial, meaning that after surgery they get radiation and combined it with hormones, and it was statistically significant with respect to survival at 10 years, 86% versus 70%. That was a very statistically survival is less than 0.004 was the p-value for those statisticians of you out there. RTOG 8531, another very powerful study. It looked at pathologic T3, pathologic lymph node disease patients, and all endpoints were satisfied to the standpoint of statistical significance, including metastases-free survival, biochemical disease survival, overall survival. Very powerful paper, and yet these doctors persist in saying there's no survival with treating lymph node disease. Don't do it, you're going to get AIDS. It's crazy. It's absurd. RTG 9202, and they found that a group of patients with Gleason 8 through 10s, if they had lymph node disease, they would benefit statistically and significantly over time from an overall survival perspective. By the way, that 8531 group, they really benefited if they had Gleason 7 through 10s. And probably is the single most powerful study which would document that you indeed have a survival benefit treating lymph nodes, and that anyone saying otherwise is wrong. The data, this is fact. This is not, this is not makeup. This is fact. These are real studies which have been done. Finally, the famous studies from Bola et al., the EORTC, the EORTC European trials, and Bola. He treated patients with advanced disease, just locally advanced disease. They were T3 disease and plus. They were bad actors, and they got hormones and radiation. And we have to believe that a sizable number of those patients, if we had subjected them to advanced imaging, if I sent those patients to Orlando, my God, they'd have lymph nodes, plenty of lymph nodes. Yet that study is famous for documenting a survival advantage in locally advanced disease. With respect to the damaging effects, whereby the immune system becomes deficient and you're subject to these infections of all kinds, AIDS infections, I actually reached out to the president of the American Society of Immunology, and he and I had numerous exchanges. And I will read to you one of the or some of the excerpts that he brought forth. He said, as you know, the temporary reduction of T cells resulting from radiation is a very well-known phenomenon to radiation oncologists and most medical oncologists, and is therefore, quote-unquote, old news. What is not discussed is the abscopal effect, indirect, unexpected effects of radiation, which actually results in an anti-tumor immune response which appears to activate other systemic elements of the immune system. Researchers have identified changes in tumor-directed antibody levels and immune cell populations which support the fact that radiation triggers the system to fight locally, but also at distant sites outside of the radiation field. Again, this is a temporary and well-known phenomenon which apparently negates the decline of CD3, CD4 T-cell lymphocytes. He went on to say that he was deeply disturbed to learn that patients are actually being asked to be almost quarantined following their radiation to abdominal pelvic lymph nodes. So I think that answers that. And the risk of bladder and colon cancer, part of that question is that's yet another controversial issue. And what I think you need to recognize is if you have prostate cancer, it's in the genitourinary system. The prostate is. And any patient who has prostate cancer is subject to has a predilection to developing renal cell cancer, which is cancer of the kidneys, ureteral cancer, cancers of the ureters. They have increased risk of developing bladder cancers, increased risk of developing testicular cancers. It's all part of the same system. This is not unique to prostate. You can look at gynecologic cancers. It's the same thing. If the woman has, a cervical cancer, they're at risk for uterine and vaginal. It's all part of the same system, the GON system. Well, in men, it's a GU system, and there is that predilection. Does radiation add to it? There are some papers saying it does, and but there have been also patients which offset that in a very in a very strong way. In a recent study showing that colorectal cancers, it was basically that as you follow the patients, well, they're getting older, and colorectal cancer is a very common cancer, and so if you're going to say, well, we're going to blame it on the radiation, you may be wrong, because the patients are just getting older, and colorectal cancer is very common, and they're going to develop cancer at an increased rate as they get older, not because of the radiation. But maybe the truth is somewhere in between. But again, you got to make a decision. Do you want to be treated or not? You want to be cured of your prostate cancer or not? And you are at that increased predilection to developing other malignancies in the genitourinary system. Maybe I've taken some notes here just because this is worth a big response. There are doctors who are issuing warnings to patients about undergoing CT scans annually during routine checkups, and even criticizing this facility, me, saying that the scan is not worth the recurrent radiation. It's not worth the risk of the radiation exposure from the CT scan, and that it's not worth the risk because it leads to an increased risk of leukemia. And it also implied that these scans were done to increase revenues instead of benefiting patients. What is your response? Well, first, let's just analyze why ionizing radiation from a CAT scan may cause cancer. Okay, first, there's the radiation particle itself, and it may hit the DNA strand and make it may make it aberrant, so it's a mutant and it can become cancerous. A secondary phenomenon is the most important one, and that is the oxygen molecule. And what happens is the incident radiation particle, the ionizing radiation, comes in photon and it hits the oxygen, and it scatters. It hits the oxygen and it scatters the oxygen into free radicals, which then go off and also hit DNA strands and can break them or change them or alter them to in a mutagenic way. So that's the thinking of why it could do it, but does it do it? Well, I think it's a myth, and I'll tell you why. First of all, let me say that it's obviously been very popular in the media. Don't get CAT scans; it increases cancer risks and so on and so forth. And you can't deny that the media has been doing that. But hey, isn't the media the same ones telling you not to get a PSA? Isn't the media or the administration the same one telling you, women, they shouldn't be getting mammograms every year? Is this maybe the reason why I'm seeing so many men with advanced prostate cancer? Because do men really want to be talking about, their prostates? Men generally are quite quiet about their own health, and let alone their private parts, and talking about erectile dysfunction and so on and so forth. So, now you tell them you don't need a PSA. Whoa, that's great. I don't need a PSA anymore. Not until they suddenly can't urinate and they're having gross blood coming out of their penis, and their prostate glands have become locally advanced and it's dispersed throughout the body. So, a problem. But what's interesting is if you look at presidents. Just think about it. We just heard about President Carter, 90 years old. Lived to 90 years old, okay? Reagan, was he in his 90s? Yeah, he had Alzheimer's, but did he have cancer? We know he had cancer in the colorectum, and everyone says, that's the reason why there's a cure for cancer, because he had colorectal cancer. Well, no, they picked it up early, okay? So there's a Supreme Court justice who had pancreatic cancer. These are people, just like President Ford lived to 91, 93, I don't know. Most presidents live into their 90s despite the stress that they go through. Okay, why? Because they get executive physicals. Okay, if you get an executive physical, Mayo Clinic is famous for it, and patients are sent there from their corporations to get executive physicals, which is what we do right here on an annual basis. I don't force it to any patient. It's an option that they can get. And yes, we listen to the media too, and the media got to me to the point where I got the latest generation of CAT scans, which is the lowest exposure, highest resolution CAT scan. It delivers 1 millisievert of radiation. Okay, it's extraordinarily low. Okay, and even the older CAT scans were only delivering like 5 millisieverts. It's a very low radiation dosage. The reality of it is we were basing all of our data on this so-called linear non-threshold model, which had absolutely no root in scientific evidence. There was no evidence at all, and that has become obsolete. We don't believe in it anymore, and shame on everyone saying these CAT scans were causing, so much radiation exposure and causing cancers and so on and so forth. Because, hey, it cost me several $1 million to go out and get another machine just to satisfy my patients. But the reality of it is, having said that, through the years, how many patients have I saved who had early stage lung cancers, which would have been advanced cancer if it hadn't been picked up on myself? Patients who had pancreatic cancer stage 1 who survived because they were stage 1 and they underwent a Whipple's, just like the Supreme Court justice that I mentioned, executive physicals, picking up disease early. Just like I said, Ronald Reagan, had colorectal being picked up early based on advanced technologies, diagnostics. I've treated I've found so many patients with renal cell cancers, and those patients would have died of renal cell cancer if I hadn't picked them up. I've picked up patients with a host of other, even benign things. Benign things like abdominal aneurysms. Do you know what's in your belly? Do you know if your aneurysm is swelling and it's going to pop any given day? Well, I could tell you if I do a scan. Meanwhile, at this facility, to get this executive physical, it costs, if you were paying out of pocket, a grand total of $433. That's probably the copay of what you would spend, if you were to go elsewhere and have all those scans done. So, shame on the doctors saying that, I'm doing this for reimbursement. No, I'm doing it to protect my patients and help my patients. Not to mention, a lot of my patients have advanced disease. I know that they had enlarged lymph nodes, and I can do 1.25 millimeter scans, and I know exactly where to look to see if those lymph nodes are enlarged. And I can tell them if their lymph nodes have regressed. I can tell them if they've come back. It's all important data. And so, again, shame on the doctors saying that. It's a problem. So part of what men believe is their executive physicals when they come here to the Dattoli Cancer Center annually. We also incorporate something called a QCT BMD. Now, what this is a elaborate DEXA scan which women get, beginning typically at age 50, sometimes sooner, but it's certainly when they're postmenopausal. For reasons that are unclear, this is just not done in men, despite the fact that men actually have increased risk for developing osteoporosis and osteopenia, much like their women, their wives or women in general. Interestingly, when men develop hip fractures, for example, they have a twofold risk of that being a fatal injury. Meanwhile, men who are sedentary, men who smoke cigarettes, men who drink alcohol, men who have chronic GI distress, men who have thyroid disorders, hyperparathyroidism, there's a host of things that men get just like women get, and their bone mineral declines. The strength of their bones decline. Now, what we can do differently, and what we do differently, is women typically get something called a DEXA scan. And a DEXA scan is a good technique, and that's pretty much a standard within endocrinology, which, by the way, the Endocrinology Society recommends that men have DEXA scans done just as they do as women, and other institutions such as the National Osteoporosis Foundation recommends that all men beginning age 50 should be getting DEXA scans similar to women, and there are other guidelines by the American College of Physicians. But anyhow, bottom line being is, what we do here is something special. When a typical DEXA scan is done, you're looking at cortical bone. Now that's the bone that you often think of when you see the skeleton. It's the outside of the bone. That's the cortical bone. However, what it can't measure is the trabecular bone. That's the inside of the bone. It's the mushy part of the bone. It's where the bone marrow is. And with our scanner, we can measure that, and it's actually a forecast of what's going to be. So in other words, your bone is what it is right now, the cortical bone, your exoskeleton. However, the inside of your bone, the marrow, is a forecast of the future of what your bone is going to be. So we look at both, because after all, if your marrow is not healthy, then that predicts that your cortical bone, your exoskeleton, is also going to be unhealthy in the future. So we look at that and we treat a patient accordingly, as if he has osteoporosis or osteopenia, so on and so forth. That's a rare test, by the way, and the reason why it's rare is your typical DEXA scan may cost $50,000, but in order to do a QCT-BMD and to track both cortical bone as well as trabecular bone and bone marrow, you need, number one, a CAT scanner, which is, you're talking about millions of dollars, and then even a software program costs hundreds of thousands of dollars for the interpretation of, or the evaluation and interpretation of the bone marrow. So this is another part of the so-called executive physical done here at the Dattoli Cancer Center, as men wish to have done. And again, they do have an option to not get it. It's not something we're pushing upon them, but most of our men are pretty savvy, and they're accustomed to getting executive physicals. Many of them are previous CEOs of companies, or are CEOs of companies, and they just are accustomed to it, and they want to have those tests done. So, as I said, I did some interesting homework. I've already told you, and I knew that, you know, our body scanner gives 1 millisievert. Well, just so you know, if you took a flight from New York to London, you get over 0.5 millisieverts, meaning if you do round trip, you got more than a CAT scan of your body. Okay, so then you have to say, gee, you know, if I'm a traveling person, you know, I'm getting a lot of CAT scans. You know, some people travel for a living, okay? What about the pilots? What about the flight crew? Do you know that they get a higher radiation dose than nuclear power plant workers? Is there concern amongst pilots and stewardesses? Are they being tested for leukemias and secondary malignancies and such? No, they're not, because it's absolute nonsense. Why do they get it? It's because they're flying so high that cosmic rays, the atmosphere blocks out a lot of the cosmic rays of ionizing radiation, and so if you're flying 30 to 40,000 feet high, well, you're kind of going into the atmosphere, and you're almost going beyond the atmosphere, or you're in the upper threshold, so you don't have as much protection from the atmosphere from those cosmic rays. So again, you know, it would be absurd to, you know, for us to be telling pilots. And again, wouldn't we all know if pilots and stewardesses and flight crews in general were getting, you know, cancers at a rapid rate? Yes, we would know that. Airplanes have been around for quite a long time. It goes on. The radiologists, they're working around fluoroscopy all the time. What about radiation technologists? What about just radiology techs? What about cardiologists? Use a lot of fluoroscopy, which is very similar to low-dose ionizing radiation. What about me? I get a pretty high dose. I'm using just handling radioactive seeds, far higher than a CAT scan, and I do that, you know, a couple times a week, and I've been doing that a couple times a week for the last 30 years. So, you know, maybe I'll be doomed by leukemia, but I'll tell you, I don't believe that it's going to be from the radiation. Interesting thing is the atomic bomb people of Hiroshima and Nagasaki, they were well tracked beyond the timing of their you know, the bombing. There was a group within the perimeter who did get toxic doses of radiation and died from radiation poisoning and toxicity, but the others didn't. And but what they were subjected to was fire, not fire from the radiation, fire burns. Okay, just you know, being burned by a fire. Just just as they were breathing in contaminated air and eating contaminated food, and these patients had an increased carcinogenic level, as did Holocaust victims, because of the stress that they lived under and malnutrition. They had a higher risk of carcinogenesis. Did they get any radiation? Absolutely not. The 9/11 people who were in the perimeter of that disaster have also been tracked, and many of them have been identified to have developed cancers. They were not irradiated. They were just in harm's way. They breathed in toxic fumes. People living in that general vicinity in downtown New York City are being followed and are developing cancers at an increased rate compared to the population at large. Again, not because of radiation, because of other things. Again, stress, contaminated air, toxic fumes, especially firefighters. And firefighters in 9/11 were, really high risk for developing malignancies and leukemias. And firefighters in general at increased risk just because of the work that they do. So are people who live around thorium. It's thorium-232. It's something which is used for ceramic and old ceramics and now for ceramic glazes. And these people, they receive fairly high doses of radiation, but do not develop secondary malignancies, and they're followed and tracked. And also, we're all getting, as we sit here, we get radiation in the form of radon, and miners especially are under, it comes from the soil, there's radium in the soil, and they can get anywhere between 1 to 10 gray, in a year, and they're not developing cancers. So it doesn't appear that it's really the radiation that's doing it. Chernobyl is another case in point. Yes, there were people in the perimeter, and if you look it up, it's somewhere between 21 to 28 people had a risk did die from radiation poisoning. But outside of that pooling of patients, it is extremely low. In fact, the very interesting fact associated with Chernobyl is 200,000 people evacuated and never came back. Okay, even though today it's a very popular destination for tourists. Okay, there were 1,250 suicides because of the radiation scare that you're going to develop a cancer, and 200,000 women underwent elective abortions because of this. Okay, again, and meanwhile, there was a small risk in patients who were close, who got 10 gray or more of developing thyroid cancers. But thyroid cancers are very curable. It's follicular. They're the most curable cancers that we know of. So really, only much greater doses can account for developing cancer, because it can overwhelm the DNA repair. That having been said, what about DNA repair? Well, we're all walking, breathing DNA repair machines, okay? Because from the beginning of time, I talked about oxygen. Well, all of life has been subject to these DNA radicals being shot out from oxygen, okay, and have learned to repair. And so there's repair mechanisms that go on within the body, which actually reduces the rate of cancer. So this has been something that's going on since the beginning of time, and it's almost perfected itself to the point where we can say that people who are subject to low doses of radiation, people living at high altitudes, the longest living people in the world actually live in the Himalayas, okay, and they have a very low risk of developing cancers, yet they're getting low risk. And so there's actually a 30% lower risk of developing cancer. So there's a theory, and it's a strong theory, that low dose radiation is actually good for you, and that's probably why it is in our soil, okay, and it's and that there's a terminology which I would again ask you to Google. It's called radiation hormesis, and what it is, it's a protective way that our bodies cope with radiation and deal with it and get rid of it and repair very nicely and take care of mutant and aberrant cells and just get rid of them. We don't allow progression of mutant cells. It's been a repair mechanism that's been in place forever, okay, and it's only gotten better over time as our bodies have adapted. So it is an adaptation of all animals, and men and animals alike. This is probably the point where I think we have to say, is radiation really toxic to us at these low doses? The answer is no. Healing springs, most healing springs have radiation in them, and that's really funny. You can research that and look into healing springs and then just put in radiation exposure. You get more dose in a healing spring, probably you get about 10 CAT scans, okay, of the old type, okay, and they're healing springs, okay, and they're all over the world. And so I think we could put that to rest. And I think I put that to rest. You can do your own research, and I think after you do, you'll put it to rest. Because I did a significant amount of research on this and found there is no risk. And again, my new associate, when I brought that up to his attention, the fact that low dose ionizing radiation, he said to me, "You mean you replaced your CAT scanner? You spent that many millions of dollars? Are you crazy?" Because he had published on this. He's a product of UPenn. He's a Fox Chase Cancer Center, NCI, NIH, brilliant guy. And when I told him about what these doctors were saying, he said, "What, are they crazy? Are they quacks? Are they kooks? What are they saying?" And he had actually published numerous papers on the topic. So I think we can close the door on this issue and move on. So in question 9, we at PCIG have been trying for several years to get equivalent Dattoli treatment from local Cincinnati doctors for those who can't go to Sarasota. They say their local docs claim they can do everything Dattoli does. What do you feel can't be duplicated here by the local doctors and the facilities that are being done in Sarasota? Well, bear in mind that this has been my bailiwick for nearly 3 decades. So I've been focused on prostate cancer for nearly 3 decades, and certainly I hate to be braggadocious, but I believe that we can do things better than any place. I did develop seed implantation certainly on the eastern seaboard. I don't think anyone would dispute I've done more than any person in the world, and I do believe that most would believe that understand that I've made most of the changes to seed implants over the past 3 decades with the aid of Sloan Kettering physicists. So that's something which I think is very special, and there are different ways that you can do a seed implant on a different patient, and there's not a one-size-fits-all seed implant. They're different, and I have the advantage of using more seeds than any person in the world, so I can pick and choose activities of seeds, and that's very important for a patient, because if you're using, again, the 3D Color Flow Doppler Ultrasound, the instrument that the doctors called a quack, quackery or whatever, the fact remains that I can see the cancers, and I can put higher dose or higher strength palladium seeds or iodine seeds, whatever it may be, into that specific area, just because I have those seeds available to me, because I've used them throughout the week or last week, and so I have different energies that I can pick, and I'll pick and choose and put higher doses where I want them to go. Another thing that we do here was actually developed right here at Dattoli Cancer Center is DART. And DART is very special for many reasons. So with DART, what we can accomplish is literally hitting a dot in space as the dot is moving. A dot the size that you make with a tip of a pen, that dot, which we call voxels. What happens is a scan will scan you, and then a software program will slice and dice you into hundreds of thousands of voxels, so you become voxelized. This is a culmination of something that's been going on for a long time, and it's been an evolution of the program, both here and dating way back to Sloan Kettering in New York City, but we've never stopped developing four-dimensional technologies. So what makes it special is that we can hit those dots, which is very important because that's all about precision. And anyone who knows about radiation wants to know about precision. How precise can you be? Well, we can be as precise as hitting a dot as it's moving. And you have to have a lot of equipments to be able to do that. For example, here at the Dattoli Cancer Center, we have exact tables, we have exact arms, we have the third generation sun array, which is my staff uses on every patient. We developed, and let me say this too, my physics team has been instrumental in developing many of these equipments, if not all of these equipments. Just to go back a little bit, we even developed a navigation system 20 years ago. Now it's called Calypso. We don't use it. We've outpaced it. We've gotten better than that. Calypso told me about the prostate, but it didn't tell me the location of the cancers within the prostate. It didn't tell me about the rectum and the bladder and the neurovascular bundles and the lymphatics and small bowel and large bowel. I needed to know everything about everything, including bony architecture. So even putting in fiducial markers, we did that over 20 years ago just to document that the prostate moved, despite a patient being under the table, and obviously you're not going to try to move while you're being treated, but your bowels are going to be moving and you can't stop that. So there's unwanted and unintentional things that occur in your body and you just can't control them, but they are going up, down, right, left, or move the prostate bed if you've had prostate surgery, or if you're being treated for lymph nodes, it's going to push them all over the place. Think about it when you start treatment. Your bladder has a certain amount of fluid in it, and that fluid is subject to change because we cannot shut down your kidneys. So 20 minutes later, your bladder is going to have more fluid in it. That doesn't mean much to places doing IMRT or IGRT. Here it means everything because they're shooting at predetermined dots, predetermined voxels. So going back, we continue to go along that line of fourth dimension because that's what it's really all about. We're way beyond the third dimension. And we developed sun array, my physics team did, and my physics team developed cone beam tomography. We do have something called onboard imaging, which is a complete system in and of itself, and third and fourth dimensional bone and soft tissue matching. We have portal vision and portal imaging, and the list goes on. And the reason why we can have this, these instruments, by the way, are very expensive. You can buy them because we worked alongside of Varian. We needed Varian, the Rolls Royce of radiation technologies. The fact is they cost hundreds of thousands, if not millions of dollars per equipment, and yet the reimbursement today is zero. So there aren't many people, just like I was explaining with three-dimensional Colorflow Doppler Ultrasound, there aren't many doctors who are going to want to go out and buy something that's going to have a zero return. It's just not fiscally wise. It's, you're going to fiscally drown yourself. So you just can't do that. It's for that reason that doctors aren't using all of these technologies. But we do, because we develop them, and if one of those instruments goes awry, if something happens over the weekend, my chief physicist will be in there fixing it because they developed it and they know how to fix it, and we don't have to pay the service contracts that others would also have to, and in addition to the price of the instrument, have to pay an annual service fee, which can range from 20 to 50, sometimes upward of $100,000 a year just to maintain a piece of equipment in the case that something does go wrong. So here at the Dattoli Cancer Center, we use all these equipments, and we did develop DART, and we put that name DART, I think, about 3.5 to 4 years ago to it, with the D meaning dynamic, the A meaning we're adjusting the microbeams to your motion, and the RT is while you are moving in real time. And this takes on great importance with the prostate, which is surrounded by such critical tissues, but also takes great importance in patients who are identified by nanoparticle technologies or advanced MR imaging or C11 choline type studies to have lymph node involvement. Those lymph nodes typically sit in precarious locations close to the liver, close to the kidneys, certainly surrounded by small bowel. So the level of precision that we can deliver with DART is second to none, and I would contest that any physician, radiation oncologist hopefully not the urologist again, going back to that, the UroRad, should be the radiation oncologist talking about this, would have a very difficult time treating lymph nodes, in the periaortic and the aortic cable and retrocaval regions in the abdomen, along with perhaps some pelvic lymph nodes, because it's going to make you ill. I can tell you many patients treated here in Sarasota, they may have some side effects, and we know how to manage them because we've been doing this for so long. But many patients actually come, during a time of year, and they actually make a vacation of it while they're being treated to these other areas which other doctors can't even do because they'd be ill and would be suffering while they're being treated, and it's just not the case. So DART is very special. It's something very special here at Dattoli Cancer Center, as is seeding, and they each have their purposes, and we often combine the two. Sometimes we just use DART for salvage patients where their cancers did return in lymph node sites, or even for in bony sites, where we can be very precise because those areas that we're treating are typically sitting around very delicate organs which need to be avoided. So anyhow, I think I've answered all the questions that you put before me. I know that many of them are controversial, and I know that I've had to give ugly answers because I think you've given me a lot of ugly questions. You guys are smart, and you gave me a lot of intelligent questions last time, and I think you've even ratcheted it up a little bit this time. But I thank you for allowing me to answer them, and I wish you well. Thank you.